Good afternoon, everyone. I am Prajwal Ghatol. I am pursuing Doctor of Pharmacy from Parul Institute of Pharmacy and Research. Today, I am going to conduct a session on targeted therapies for neoplastic disease. Many new drugs, either recently approved or in later stages of evaluation, were designed to block the fundamental mutations that cause specific cancers, that include dysregulated intracellular signaling pathways, defective DNA repair and apoptosis, and tumor angiogenesis. The primary tools for inhibiting these new targets are tyrosine kinase inhibitors, monoclonal antibodies, and cytokines. So, today, let's discuss about all these topics. Tyrosine kinase inhibitors. So, why these tyrosine kinase inhibitors are used? To know that, we would need to know that what tyrosine kinase is. So, tyrosine kinase. Protein kinases are critically components of signal transduction pathways that regulate cell growth and adaptation to the cellular environment. The human genome contains approximately 550 protein kinases and 130 phosphoprotein phosphatase that regulate the phosphorylation state of key signaling molecules. The protein kinases can be classified into three categories: the kinases that specifically phosphorylate tyrosine residues, kinases that phosphorylate serine and threonine residues, and kinases that shows activity towards all three residues. Tyrosine kinases can be subdivided into receptor tyrosine kinases and non-receptor tyrosine kinases. So the question arises here is why we need to inhibit tyrosine kinase for for treating cancer. So in the growing number of human malignancies, mutations that consecutively activate protein tyrosine kinases are implicated in malignant transformation. Thus, protein tyrosine kinases are targeted for cancer therapies. The most common one in protein kinase is ACR-ABL kinase. So we will discuss the inhibitors of ACR-ABL kinase that are imatinib, dasatinib, nilotinib. So what is BCR-ABL kinase? BCR stands for breakpoint cluster region and ABL stands for Abelson proto-oncogene kinase. So this need to be inhibited as it leads to malignant phenotype. Imatinib mesylate was the first molecular targeted protein kinase inhibitor to receive the FDA approval. It targets the BCR-ABL tyrosine kinase, which underlines chronic myelogenous leukemia. In this, a single molecular event takes place, that is, the translocation of 9 and 22 chromosome that leads to the expression of ABL fused to BCR, which yields a consecutively activated protein kinase, BCR-ABL, which leads to malignant phenotype. These are the structures of the drugs that are the inhibitors of BCR-ABL kinase, which include imatinib, dasatinib, and nilotinib. You can have a look on the structures. The mechanism on which these inhibitors work is that they fixes the enzyme in a closed or a non-functional state so that the further malignant phenotype does not occur. Uh, uh, Crystallographic and mutagenic studies indicate that imatinib and nilotinib bind to a segment of a kinase domain that fixes the enzyme in a closed or a non-functional state in which the protein is unable to bind its substrate phosphate donor ATP. Let's discuss the pharmacokinetics of all the drugs. Imatinib. Imatinib is a well absorbed after oral administration and it reaches the maximal plasma concentration within 2 to 4 hours. The half-life of imatinib and its major active metabolite, that is the N-desmethyl derivative, are 18 and 40 hours respectively. Food does not change the pharmacokinetic profile of imatinib. Cytochrome 3A4 is the major enzyme responsible for metabolism of imatinib. Dasatinib is also somewhat similar to imatinib, the pharmacokinetic, but the metabolite of dasatinib are inactive, and it is also very well absorbed when taken orally. The bioavailability of dasatinib is significantly reduced at neutral gastric pH, resulting from antacid and H2 blockers. It is also unaffected by food. Nilotinib. Approximately 30% of an oral dose of nilotinib is absorbed after administration, and the drug achieves peak concentration in plasma 3 hours after dosing. Unlike the other inhibitors, nilotinib bioavailability increases significantly in the presence of food. The drug has a long plasma half-life, that is approximately 17 hours, and the plasma concentration reaches steady state only after 8 hours of daily dosing. Clinical use. Imatinib shows remarkable therapeutic benefits in patients with chronic myeloid lymphoma, chronic, chronic myelomonocytic leukemia, hypereosinophilic syndrome, and dermatofibrosarcoma protuberans. The three BCR-ABL kinase inhibitors differ in their potency of inhibition, their binding specification, and the susceptibility to resistance mutation in the target enzyme. The adverse drug reactions of these drugs include GI distress, that are diarrhea, nausea, and vomiting. All the three drugs promote fluid retention, which may lead to dependent edema and periorbital swelling. Dasatinib may cause pleural effusions, and nilotinib may prolong the QT interval, and should be used with caution in patients underlying heart disease and arrhythmias, although ventricular arrhythmias have not been reported. Significant myelosuppression occurs infrequently, but may require transfusion support, dose reduction, and discontinuation of the drug. Although all the three drugs are associated with hepatotoxicity, after the adverse reactions are resolved, the drugs can be reinitiated and titrated back to the effective normal doses. So as we discussed, now let further proceed to inhibitors of angiogenesis. So what does angiogenesis mean? Angiogenesis means the formation of new blood vessels. These new cancer cells secrete angiogenetic factors that induce the formation of new blood vessels, and that guarantee the flow of nutrients to the tumor cells. These angiogenetic factors include VEGF, vascular endothelial growth factors, fibroblast growth factors, transforming growth factors, and platelet-derived growth factors. Multiple tumor types overexpresses these angiogenic factors. Several animal models have demonstrated that tumor secretion of proangiogenic factors turns into an angiogenic switch, a process essential for tumor growth and metastasis. The gist of this is that the new blood vessels that are formed, they will provide nutrition to the tumor cells and promote its growth, and these tumor cells will secrete further angiogenic factors that will lead to the further synthesis of new blood vessels. So the earlier we discussed the various angiogenic factors. The most studied among the angiogenic factor is the VEGF, vascular endothelial growth factor. So how does it cause malignancy, and why is it is related to malignancy? Is that VEGF, it binds to the receptor family, that VEGF receptor family, which include VEGFR1, VEGFR2, and VEGFR3. After binding to the receptor family, it initiates endothelial cell proliferation, which leads to the activation of intracellular VEGFR tyrosine kinase activity, and initiates mitogenic and anti-apoptic signaling pathway within the endothelial cell. So, as we discussed that this VEGF is responsible for malignancy as it activates the intracellular VEGF tyrosine kinase and initiates mitogenic and anti-apoptic signaling pathways. So it needs to be inhibited. So certain antibodies are used for the treatment of for cancer. That is Bevacizumab is an antibody that targets VEGF. Uh, Bevacizumab is an antibody that directs against VEGF-A and was the first FDA-approved molecule that specifically targeted angiogenesis. As a as a single agent, it delays the prolongation of renal cell cancer, and with the combination with other chemotherapeutic cytotoxic drugs, it effectively treats lung, colorectal cancer, and breast cancer. The clinical use of bevacizumab now have expanded beyond the realm of oncology. Bevacizumab restores hearing in a patient with progressive deafness due to neurofibromatosis type 2 related tumors. The pharmacokinetics of bevacizumab include it is administered intravenously as a 30 to 90-minute infusion. In metastatic colon cancer, it is given in combination with chemotherapeutic agents with 5 mg per kg every 2 weeks. In metastatic non-small cell cancer, the dose is 15 mg per kg given every 3 weeks, given in combination with other chemotherapeutic agents. For treatment of metastatic breast cancer, 10 mg per kg is given every 2 weeks with combination with paclitaxel. The antibody has a plasma half-life of 4 weeks. The adverse drug reactions of bevacizumab include the major adverse drug reaction is bleeding, as it uh, it stops the formation of new blood vessels and disrupts it. The vessel injury and bleeding are the major side effect of bevacizumab. It is contraindicated in patients who has a history of hemoptysis, brain metastasis, and bleeding conditions. The safety of operating on patients treated with bevacizumab continues to the major concern because of the risk of bleeding and poor wound healing. Thalidomide. Thalidomide is a very popular drug, and it is famously known for the thalidomide tragedy that occurred in UK in 1960s because of its teratogenic effect in the neonates and the limb defects that occurred due to thalidomide, after which it was stopped. But here we will not discuss about the teratogenic effect. Thalidomide here we will discuss about the uses of thalidomide in cancer treatment. Among the thalidomide is an immunomodulatory analog which has anti-angiogenic activity. Thalidomide and lenalidomide are used in as an anti-cancer agent. The classification as angiogenic is convenient but tentative. Thalidomide originally entered development in the 1950s for the treatment of pregnancy associated morning sickness, but was withdrawn from the market due to the tragic consequences of teratogenesis and dysmelia. It re entered the clinical practice initially because of its clinical efficacy in erythema nodosum leprosum, for which it uh, received approval in 1998. Erythema nodosum is an inflammatory condition characterized by inflammation of the fat cells under the skin, resulting in tender red nodules or lumps. So, why is thalidomide used in anti-cancer as an anti-cancer agent? As after the clinical after it was introduced in clinical practice for erythema nodosum leprosum, it was later found out in various studies that it is very beneficial in multiple myeloma. Its anti-angiogenic and immunomodulatory effects triggered experimental trials in cancer, notably against multiple myeloma. Here you can see the structure of thalidomide. Both thalidomide and lenalidomide possess potent activity in newly diagnosed and heavily pre-treated relapsed multiple myeloma patients. The mechanism of action of thalidomide as an anti-cancer agent. The precise mechanism responsible for this drug with clinical effects are unclear, but there are four potentially complementary mechanisms that explain the anti-tumor activity of thalidomide and lenalidomide. The first mechanism, it suggests that direct it directly produce anti-tumor effects by inhibiting the NF kappa B and the BCL2. It also indirectly inhibits the tumor's growth and survival. It also inhibits interleukin 6 and TNF alpha, and it enhances the natural killer cells and T cell mediated cytotoxicity. Here, the important point to note is that it inhibits three factors, and one factor is enhanced, that is the natural killer and T mediated cytotoxicity. Here is a pictorial representation of the mechanism of action of thalidomide as an anti-cancer agent. So the proposed site of actions for thalidomide are given in this diagram, A, B, C, and D. The A is directly anti-multiple myeloma effect on tumor by inhibiting the NF kappa B and interleukin 6. The B is the inhibition of addition of multiple myeloma cell to the bone marrow stroma. It stops the addition to the bone marrow stroma by inhibiting the interleukin 6 release. The C is that it decreases the angiogenesis by it decreases the angiogenesis by inhibiting the various factors that are stated here, and D is that it enhances the T cell production and interleukin 2 and interferon gamma, and enhances the natural killer cells. The pharmacokinetics of thalidomide is that it is given in 200 to 1200 mg per day. It is treating multiple myeloma. Doses usually are escalated by 200 mg every 2 weeks until the dose limiting side effects occur. It is very slowly absorbed in the GIT tract, and it is highly variable. The peak levels are achieved in 3 to 4 hours, and the half-life of disappearance of the enantiomer is approximately 6 hours. Thalidomide and its metabolite are excreted in urine, while the non-absorbed proportion of the drug is excreted unchanged in feces. The clearance of the active drug is primarily attributed to the hydrolysis. Thalidomide enhances the sedative effect of barbiturates and alcohol. Adverse drug reaction. As we discussed earlier, that it produces teratogenic effect and limb defects in neonates, so it is highly not recommended and it is highly contraindicated in pregnancy. Other than that, it is well tolerated at dose that is less than 200 mg daily for multiple myeloma. Other side effects are sedation and constipation. The most serious one is peripheral sensory neuropathy. Thalidomide-related neuropathy is an asymmetrical, painful peripheral paresthesia with sensory loss, commonly presenting with numbness and numbness of toes and feet, muscular cramps, weakness, signs of pyramidal tract involvement, and carpal tunnel syndrome. Monoclonal antibodies. Various monoclonal antibodies are used as an anti-cancer agent for treating cancer. Few of them are rituximab, ofatumumab, and elimtumumab. Rituximab is a monoclonal antibody that targets the CD20 B cell antigen. Monoclonal antibody binding to CD20 generates transmembrane signals that produce autophosphorylation and activation of serine tyrosine protein kinase, induction of CMYC oncogene expression, and expression of major histocompatibility complex class 2 molecules. CD20 also may regulate transmembrane calcium 2 plus conductance through its function as a calcium channel. It is unclear which of these actions relates to the pharmacological effect of rituximab. Rituximab is approved as a single agent for relapsed indolent lymphomas and significantly enhances the response and survival in combination with chemotherapy for the initial treatment of diffuse large B cell lymphoma. Rituximab has a Rituximab has a half-life of 22 days. The drug is administered with IV infusion as a single agent or in combination with other chemotherapeutic agents at a dose of 375 mg per meter square. As a single agent, rituximab is given weekly for 4 weeks with maintenance dose every 3 to 6 months. In combination with other chemotherapeutic agents, the drug may be administered every 3 to 4 weeks with chemotherapy for up to 8 doses. Thank you for the session. Thank you. I hope you like the session and you learned something new.